So not wanting to be sort of the bad news guy, but the one thing that scares a lot of us with CLL is Richter's transformation, which it seems like every paper I read, the number keeps getting higher and higher now. The last one I read was 15% develop Richters. So part of that has to be that we're living longer, but I'm not hearing much at this conference about Richters and the treatment of Richters. So what's your perspective on that? Do you think it's becoming more common? Do you think that's real? Is it just because we're living longer? And do you have any thoughts about where the treatments and research has to go in that?
So first let's define Richters. What is Richters? There are a lot of different types of lymphomas that are out there. The most common type of lymphoid cancer is actually an entity called diffuse large B-cell lymphoma, DLBCL for short. And Richter's syndrome is where the CLL actually acquires new mutations, new mutations is the best way to put it, and that becomes diffuse large B-cell lymphoma. The same can happen in follicular lymphoma. We give it a different name. That's called histologic transformation. But Richter's syndrome and histologic transformation are very similar. And there are two main types of Richter's syndrome, clonally related and clonally unrelated. And the clonally related is kind of the one I explained earlier. You have CLL, it acquires new mutations, whether that's a Notch mutation or a Cyclin abnormality or a P53 abnormality or MYC activation, some new feature that then really turns it into a very aggressive lymphoma. Clonally unrelated probably stems from the fact that patients who get lymphoid cancers are probably prone to getting lymphoid cancers, and you can actually get a second cancer that's totally distinct from the Richter syndrome, which is the clonally related. And those two have a very different prognosis because one is lots and lots of mutations and one is probably maybe a less smart lymphoma. So those that are clonally related have a worse prognosis than those that are clonally unrelated. And it's about a 4-to-1 ratio.
And is that something you can test on the specimen? It's not that easy, is it?
Not yet. You could, in theory, measure the B-cell receptor between the two and see if they line up. That would be the easiest way to do that. That's pretty much a research technique right now. But the management of Richter's syndrome tends to be a multi-chemotherapy regimen such as R-CHOP. Depending upon how well a patient is, you may consider stem cell transplant in that circumstance, maybe not. Depends on if you get a full response. The prognosis for clonally related Richter's syndrome is oftentimes about a year once it happens, plus or minus. So it is a concern that we're seeing it. Your question to me was, it seems like we're seeing more and more of it. I think patients with CLL are less likely now to die of infections, less likely to die of other bone marrow failures and so forth. And so as you get rid of these other competing causes of mortality, you're seeing maybe an emergence. So perhaps there might be a greater frequency with some of the new drugs because you're avoiding all the other problems, but perhaps not avoiding this one. Maybe, maybe not. I mean, some people are a little bit worried as to whether or not disease that relapses after one of these drugs might be more aggressive, but we don't know. We really don't have the tools yet to figure that out.
Any research that you think is exciting in Richter's? I'm not hearing a lot or reading a lot about Richter's research like you are with CLL, which seems to be exploding.
Perhaps at ASH we'll see some updates on some things that I'm actually pleased our group's been a part of. But you're right, it's actually not an area of very active research currently.
All right. Any final thoughts from iwCLL 2013 that you want to share? Anything that you think is important or exciting for you?
You know, we're at a turning point, and I think everybody here sees that. The questions that are asked from the podium are so fundamentally different than the questions that were asked even 2 years ago. Last year I was here in Cologne for the German CLL study group, and ibrutinib and idelalisib were relatively novel concepts to a lot of people, and this year Everybody knows about them, and it's exciting. These are new drugs that are effective and less side effects. So I think that there is hope on the horizon for quite a few people.
Dr. Sharman, thanks for all that you do for the CLL community. It's so appreciated. Thanks
So much.